Good afternoon. Bonjour à toutes et tous. My name is Melanie Drew, and I'm the Director of Health Services here at Concordia University. I'm absolutely delighted to be able to welcome you to this event because I know it will be thought-provoking, engaging, and touching. Likely most of us in this room have had some sort of experience with cancer, be it personally or through the experience of someone close to us. So this is a topic that should be discussed and even debated. Without further ado, I would like to invite Dr. Lowy, our President and Vice Chancellor of Concordia University, to say a few words of welcome.
Thank you very much, Melanie. Ladies and gentlemen, good evening, good afternoon at any rate. Bonsoir, mesdames, messieurs. Quel plaisir de vous voir ici. Je vous souhaite la bienvenue, une chaleureuse bienvenue ici à l'Université Concordia et surtout nos visiteurs d'ailleurs. I'd like particularly to welcome the visitors whom you're going to hear from very, very shortly, both from Montreal and from elsewhere, from across the country, in fact, speaking about a very important topic. And we're very, very fortunate, in fact, to have people here tonight who have really fought and marshaled fight against cancer. I also personally have the pleasure of seeing some old friends, including Simon, with whom we share a bit of a past, and Mike, who's frequently at Concordia, and we're very pleased to have him here. And our own students are going to be contributing. And of course, who doesn't know Stephen Lewis in this country? His contribution, of course, is tremendous in so many ways. And since he's going to be introduced later, right, Mike? I'm not going to intrude on your territory, except to say that it's always a pleasure to welcome Mr. Lewis. Happily, this happens more frequently nowadays than it has in the past, and we're very fortunate that I think this is twice or three times within the year, Stephen, that you've been here in Montreal with us. So I just want to welcome you all. I think this is a fantastic cause. I'm glad that some of us are here, and I think let's let the program roll along. Thank you very much, Melanie.
Thank you, Dr. Lowy. I would now like to introduce Pat Kelly, CEO of the Campaign to Control Cancer. Pat began her career in advocacy in 1987 at the age of 35 when, as a young mother, she was diagnosed with breast cancer. Since then, Pat has established networks of cancer patient groups, written and published 6 editions of the book, What You Need to Know About Breast Cancer, published 3 manuals for group facilitators, including Leadership from the Heart, a guide for cancer self-care groups. Pat holds an undergraduate degree in medical sociology, was a former immunology research technologist, and holds a Master's of Arts in Leadership and Learning. Pat and her family make their home in Nova Scotia and in the mountains of Western North Carolina. Please join me in welcoming Pat Kelly.
Thanks so much, Melanie. On behalf of the C2CC, I want to first express our thanks and appreciation to Melanie and to Dr. Lowy and to the team here at Concordia, who have invested substantial resources, time, communications, planning, and they've helped to promote our event and to make you available to us for our presentation today. The Campaign to Control Cancer is closing the People vs. Cancer Tour for 2011 today at Concordia as a way to recognize and support Concordia's innovative leadership in the teaching and practice of communications. You engage people in learning, leading, and ensuring that knowledge is both generated and applied. Those are the goals of the C2CC, to apply what we know and learn about cancer control to cut cancer down to size. More control, less cancer. We're bringing the People versus Cancer here to inspire, engage, and frankly, to recruit Concordia students and faculty in our endeavor. But as we've traveled across Canada this year and last with Stephen Lewis, we've had a chance to have feedback from students to share, and I'd like to share some of those learnings with you. And here's a short list of some of the things I've learned. When mobilizing for change, it's not what you say, it's how you make people feel. People want to feel inspired, confident, energized, hopeful, and no one does this better than Stephen Lewis. It's been said of him that now that he no longer has a job at the United Nations, he could take his life in one of two directions. He could become a generic, and I thought it said geriatric, so I apologize. He could become a generic, angry socialist with a good vocabulary, available to make predictable comments on unjust wars. And even if he chose that course, his name would still be spoken with gratitude for the work that he's done fighting HIV and AIDS in Africa. And it would continue to be attached to a worthy foundation. But his personal work would no longer be extraordinary or useful. Or he can use his new freedom to become an independent voice in the world, the conscience of good people beholding to no one. And if he talks, and in his talks for the People versus Cancer, if his comments are any indication and the response that we've had, he's chosen the second course. He is no longer the UN Secretary General's Special Envoy to Africa, but his popular influence has never been greater. His skills as an orator and his ability to read the mood of a crowd and surface and mirror back the deeper human spirit was never more evident than in the eulogy for Jack Layton. Illuminating with grace and humor a life of service, a life well lived, and a life well loved. We want to thank him for that. It's not enough to inspire, though. People want a clear case for support, evidence for what the right action is or might be, and a way to make a contribution in a sense that our contributions will matter, especially in a challenge as big as taking control of cancer. 1 in 3 of us will be diagnosed. It will soon be 1 in 2. It doesn't have to be this way. We could cut cancer in half in 1 generation by applying what we know today. So, to speak to that case for support, we have Simon Sutcliffe from the Canadian Partnership Against Cancer here to make the case for universities to take up the challenge of ensuring that institutions are not only a place where knowledge is generated, but a place where we build capacity to make change happen, to make research relevant, to build capacity for sustainable partnerships, and to make advances move from the bench to the bedside and into our communities at the speed of Twitter. Dr. Sutcliffe is himself a pioneer in making change happen within cancer systems. He's a longtime friend and a colleague who has taught me some valuable lessons in advocacy, including that if you're going to do anything pioneering, you're going to get arrows in the back, and you just have to put up with it. Don't complain, just work harder, and above all, never give up. The last lesson, and probably the most important one, university students at McMaster, at Calgary, and last year at Carleton said, the People versus Cancer Tour was a call to action, but much of the feedback that we received from students was the feeling that they didn't know what to do next. And this is especially relevant because the health challenges of university students include drug abuse, alcohol consumption, including binge drinking, smoking cessation, nutrition, obesity, mental health, including suicidal thoughts, lack of a sense of belonging, stress, fatigue, sexuality, including sexually transmitted diseases and contraception. All of these are modifiable risk factors for cancer. What you do now, the habits and behaviors you have, carry forward into your career and into your families. So students from Carleton are here today, and they were so inspired by the People versus Cancer Tour last year with Stephen Lewis that they've worked with us on a project entitled Engaging Emerging Leaders in Cancer Control in Ontario. Kamal Minus and her team, Kamal, nice to see you and nice to see all of your colleagues with you here today, are taking action and taking control at Carleton, and they are pioneers in a new kind of cancer mob. We've got vote mobs, now we've got cancer mobs. And that's going to take this campaign into campuses across Canada. That's our vision. So you wanted a few ideas for action, and I'm going to make this short. Tobacco control. There was a campaign launched in the U.S. called the Truth Campaign, and the program set out to drive a wedge between the tobacco industries, advertising, and a youth audience. The program not only assembled a team of advertising and public relations firms, such to the strengths of Concordia and communication, But they also polled Florida's youth directly, and from this emerged a campaign concept of a youth movement against tobacco companies that promoted through grassroots advocacy and a youth-driven advertising campaign that in fact had a larger impact on reducing new smokers in tobacco than any other effort. Colon cancer screening. In an effort to send the message of the importance of colorectal cancer screening, the American Cancer Society has launched an innovative social media campaign called Tag to Nag. The campaign follows Facebook users to encourage their friends and families to get recommended colon cancer screening by tagging them in images that feature prevention messages. Food security, huge issue for young adults and for students. There's a program in Canada called Meal Exchange, and it's a national student-funded, youth-driven, registered charity that organizes to address local hunger and food sustainability, and it's mobilizing the talent and passion of students. Skin cancer. In the British legislature, there are age restrictions now, and in the US and in Canada, on using commercial tanning salons. Young adults have the power to shut down the tanning bed industry. The Indoor Tanning Association claims it's a decision that should be left up to young adults and their parents, releasing statements that read, if such a law were to pass, a 17-year-old could drive a car, get married, have children, go off to college, join the military, and still not be allowed to tan indoors. Well, this was a quote that I found on online, of course. A 17-year-old could watch Jersey Shore or any other MTV programming for that matter, which we think should be convincing enough to stay out of the tanning booth. Oral cancer. There's a prolonged sore throat was once considered a cancer worry mainly for smokers and drinkers, but today there's another risk. Sexually transmitted disease is fueling a rise in oral cancer, particularly among young males. But the HPV virus is known to cause cervical cancer, but it can also cause cancer in the upper throat, and that's an issue that I think is only just beginning to surface in university campuses. Binge drinking. There's a series of advertisements warning 18 to 24-year-olds about the consequences of binge drinking in the UK. And the images show young people injuring themselves, being violent, smearing vomit in their hair. And the campaign in England and Wales asks, you wouldn't start a night like this, so why end it this way? The adverts are shown in the evening and late at night to catch viewers both before and after nights out. And lastly, I want to mention asbestos mining. Asbestos is mined in Quebec, and 95% of the product is exported to developing countries. Asbestos causes lung cancer and mesothelioma. It's primarily mixed with cement, a practice now banned in every other country in the world, in every other developed country in the world. There is no justifiable position for our government in terms of continuing to fund the Crystallite Institute in Quebec, and you have the power to influence that. There is a campaign called Canada Causes Cancer. If you're interested, go online, you can see it, you can join it, you can make a difference. Another thing you can do is join us in community conversation. We've created a downloadable toolkit with a series of questions you can use to host a series of student-led conversations. There's an online survey that can capture your comments, and we'll provide all participants with a copy of the reports that you generate and contribute to. And we'll generate a report for every province that participates, and those reports will be presented to provincial governments in the fall of 2012 when we host, once again, Cancer Day of Action in provincial legislatures. You'll find information on the postcards that we've been handing out today. So we are proud to be here today and excited about the new ideas, the new energy, and the new momentum that's going to follow through your student engagement. But we couldn't be here today without our national sponsor, Sanofi-Aventis. We've worked with them for 10 years, and it's hard as an advocacy group to find funding and to find values-based partnerships that are as productive and as long-term as ours. And as Mother Teresa had said, to keep a lamp burning, we have to keep putting oil in it. To keep us out there, we have to continue to have innovative partnerships like the ones that we've had with Sanofi-Aventis. But I think the most important learning I want to take away from this tour is that leading your life in a meaningful way is never just about you. It's about you, and it's about the people that are around you. And I hope you'll join us in this fight to take control of cancer. Thank you.
Yes, please. Thank you, Pat. The next speaker is a student studying accounting in the John Mosen School of Business here at Concordia. Anthony Hunt is a Montreal native who is in his final year of studies. In my conversations with Anthony, I have appreciated the candor and openness in telling me how cancer has had an impact upon his life and his family. I would now like to invite Anthony to share some of his story with us.
I'm a little nervous. Better. Hello? Good. Good enough? No. Thank you. My mom, Shirley Fee, was diagnosed with stage 4 lung cancer at the beginning of November 2009. She had a large tumor spread over her back, both lungs, 2 ribs, and part of her adrenal gland. She went through extensive chemotherapy and radiation, and with the assistance of alternative medicine, she had managed to diminish the tumor to nothing but the size of a quarter. Unfortunately, in 2010, she was diagnosed with a brain contusion, finding a large tumor in her skull pressing against her brain. Fortunately, within the following weeks, she underwent surgery and was said to be fine. The summer and fall were a great time for Mom. She traveled with her loving husband throughout the US and Canada. It was only in November 2010 that another traumatic event happened, this time to my father. Prior to the trip, Dad suffered from medically severe breathing problems. But while on a cruise nearing the port of Dubrovnik, Croatia, my father fell very ill. He was diagnosed with pneumonia and was rushed to the hospital upon arrival. He was placed in the intensive care unit under critical conditions. The doctors, knowing very little about my father's previous condition, didn't know what to do. So, with car keys in hand, the head doctor of the ICU was literally leaving my father to die. Mom rushed out and with great love and determination said, "Go save my husband." With the use of proper technology, Mom managed to get all medical files transferred to the doctor's iPhone. That night, the doctors saved my father's life. For that and many other things, I'm eternally grateful. The same was not the case in January 2011. Mom's lung tumor returned with a vengeance. Within a couple months, she underwent spinal surgery paralyzing her from the waist down. At the beginning of June, Shirley Fee lost her life to this horrible disease. The past 2 years have been a challenge, to say the least. School has always been a priority for Mom. I not only wanted to make her proud, but myself as well. But when a person that means so much to you is suffering from such an illness, everything about you is shaken to the core. It changed me. This disease changed me. Even so that in spring 2010, I was placed under academic probation for the second time. Under Concordia's procedures, I should have been suspended from school for a 2-year period. When I heard this, my life as we know it dropped. My beliefs, my goals, my determination was lost. School was who I was. It was who Mom taught me to be. To this day, I am eternally grateful that Dr. Kanan, the Dean of Students at JMSB, allowed me to stay in the program. This is just an example that in the darkest of times, you can feel loved. It has come from my teachers, knowing that I couldn't be at every class, but still willing to help me in any way possible. It has come from therapists and doctors who have instilled in me the confidence that I had lost and has given me the strength to adapt to this life-changing event. It has come from my friends, whether it was listening to me when I needed to talk or distracting me when I needed to be distracted. And finally, it comes from those closest to me, because they have shown me that even if my mom is gone, that there is always someone that can give you the feeling of that to be loved. To conclude, cancer is a horrible disease. For me, it's taken my mother. But whether you are a teacher, an employer, or just a friend, if you know somebody affected by this, you can make an astronomical difference. Believe it, you have more power than you think. Thank you.
The next voice that you will hear will likely be familiar to many of you who are listeners of CBC Radio 1. Mike Finnerty is the host of Daybreak, Montreal's morning show. Prior to his return to Montreal last year, Mike was multimedia news editor for Guardian.co.uk in London. He also worked for 10 years covering global news and traveling the world for BBC World Service. At Daybreak, Mike speaks every morning to Montreal's newsmakers, including Dr. Lowy not too long ago. And along with the Daybreak team, he wakes the city with a full CBC breakfast of Montreal global news, business, sports, arts, weather, and traffic. Please join me in welcoming Mike as our moderator. Thank you.
Good evening, everyone. Bonsoir, tout le monde. It is always great to be at Concordia. Anthony, your words were just absolutely remarkable. I think we're all still recovering from them, and your bravery. Where are you anyway? There you are. Your bravery to get up here and to speak so candidly about what happened to you is really impressive. As I say, it's always great to be at Concordia, and thank you for inviting me, and especially tonight for the People versus Cancer to moderate this discussion about something which, let's face it, ends up affecting each and every one of us at some point or other in our life, and sometimes far younger than we might have imagined. And something which has the capacity to make us feel so helpless and powerless. Your panel tonight aims to turn those feelings of powerlessness and helplessness on their head. I'm going to introduce them. I'm going to ask them, first of all, to come up and take their seats here in front of the stage. I will introduce all four of them now, and they're going to come to the podium one after the other to speak to you. There will then follow about, we've got an hour where you're invited to participate by asking questions, whatever makes you feel comfortable, however you'd like to participate, whether just by listening or by participating in the discussion, and I will moderate that. That'll be after we hear from each and every one of them, so please feel at ease to participate however you like. So, our panel. Joanne Kennedy is the Director of Communications of the big pharmaceutical company Sanofi Canada, a member of the Women's Executive Network. She lectures at McGill in Corporate Communications and Government Relations, and I believe, Joanne, cut your teeth in government developing policy in something we call the Information Superhighway, which I gather has caught on since that time. Louise Dandiron is Concordia's Vice President, Research and Graduate Studies, and a member of your much talked about Board of Governors and Senate. Prior to coming to Concordia, she was the first President and CEO of Le Fonds de Recherche sur la Société et Culture. Simon Sutcliffe, Chair of the Canadian Partnership Against Cancer, formerly President of the BC Cancer Agency until the end of 2008. Dr. Sutcliffe is a medical doctor. He was President and CEO of Ontario Cancer Institute Princess Margaret Hospital and responsible for academic development in oncology at UBC. And Stephen Lewis, who is one of Canada's great humanitarians. I do know him, remember fixing interviews for him from my time when I was at the BBC World Service, when we were great admirers of his and his work as UN Special Envoy for HIV and AIDS in Africa. That was in 2001 to 2006. Author of the best-selling book Race Against Time, holder of 34 honorary degrees from across Canada, board chair of the Stephen Lewis Foundation of Canada, which is dedicated to turning the tide of HIV and AIDS in Africa. He is also a member of the board of the Clinton Health Access Initiative, companion of the Order of Canada, former leader of the NDP in Ontario, and of course Canada's ambassador to the United Nations from 1984 to 1988. Ladies and gentlemen, your panel, beginning with Stephen Lewis.
Thank you, Mike. Thank you, Melanie. Thank you, Dr. Lowy. It's always good to be back at Concordia. I always feel self-conscious because I'm a hopelessly unilingual Anglophone, and I have enough reverence for the French language not to do it violence in your presence. So you will forgive me if I rely entirely on English. I have never before, Pat Kelly, been introduced as a geriatric socialist. And it is an appellation that I shall cherish for the rest of my life, which may not be very long since I'm inching into my dotage in any event, and therefore the description is entirely accurate. Like Mike, I was profoundly moved by what you said, Anthony, and the way you said it. It's such an eviscerating emotional turmoil to go through all of that with a family and to lose a mother. We had a young student, Pat, if memory serves me, in Calgary, president of the Student Council, who took the platform and described the loss of his very best friend at the age of 17, and similarly moved the audience. And I sense, as we've moved from campus to campus, that there is always this sensibility amongst individual students on campus who have dealt with cancer. I dealt with it in my own family, my own wife, but one of my closest friends in the world, Eve Ensler, who many of you will know is the author of the Vagina Monologues and is the astonishing head of the international NGO V-Day. Eve Ensler, in the last 2 years, went through 3 simultaneous cancers that were discovered and managed, after all of it, to emerge, as so many people do, with a tremendous sense of resilience and strength, continuing to write books and plays and screenplays and speak everywhere from the Congo to San Francisco. And it's an important recognition that in these struggles there is so much that can occur that is of tremendous benefit to everyone around and in the years that transpire. Anthony, you fixed everyone in this room. Thank you for doing that, because it sets such a context. I was really tickled that Pat spoke as she did. She hasn't done that before in a more formal way as you did. And it was wonderfully illuminating, because Pat has such a tremendous wealth of knowledge, and I have learned a great deal from Simon, as you will shortly understand, who speaks with a clarity and a lucidity about this subject matter, which is tremendously of value. So I think with our other colleague panelists, this will be an interesting entry into this world of what I would choose to call non-communicable diseases, with a particular focus on cancer. The context for me, if I may, is the first ever summit, which was held in New York just 2 to 3 weeks ago, on non-communicable diseases. Fascinatingly enough, there had never been such an international colloquium dealing with the NCDs, as they are called, and which brought together most of the ministers of health in the world and a great many of the presidents and prime ministers as well, who were in the United Nations because the General Assembly had opened and chose to attend the sessions on non-communicable diseases. And it's interesting to reflect for a moment why it was that in those days of September, I think the 19th and 20th, if memory serves, everybody came together for that purpose. It was, interestingly enough, triggered by the reference to HIV and AIDS because the entire world had been consumed for a decade with communicable diseases, AIDS, tuberculosis, and malaria in particular. And back in the year 2000, for the first time ever dealing with a health issue, the Security Council of the United Nations had focused on AIDS. And then when the Millennium Development Goals were fashioned in the year 2000, the sixth goal was to confront and subdue the communicable diseases of AIDS, tuberculosis, and malaria. And it's quite fascinating that at no point in the range of discussion around the 8 goals that were to be achieved by the year 2015 was anything said about the non-communicable diseases as recently as the year 2000. And then in 2001 and 2006 and 2011, there were successive political declarations held internationally emanating from the United Nations in New York on AIDS. And it was time, everyone felt, that this tremendous focus, entirely legitimate on a communicable disease, but a disproportionate feeling that the non-communicable diseases, in particular cardiovascular diseases and cancer and diabetes and chronic pulmonary diseases, that these were causing a greater number of deaths around the world and causing tremendous havoc, medical and human havoc in developing countries, that we had to come to grips with the phenomenon. Thus, the international gathering on non-communicable diseases. The Achilles heel in all of this was the sense, widespread, suffused amongst the discussants, that there had to be more resources to cope with what was happening internationally. And the resources, and this is a question which has to be met, both in the partnerships which Pat described, but generally in dealing with the world of research and prevention and treatment and care, the resources are drying up. The resources are either being flatlined in some of the major countries like the United States or simply drying up. Our own government has frozen foreign aid, for example. And this is an ominous development which rings alarm bells immediately. The Global Fund to fight AIDS, tuberculosis, and malaria just last week postponed its next session of contributions well into 2012, which was completely unexpected, and announced that the $1.5 billion they anticipated having had shrunk to $800 million, virtually cut in half, and that the consequences, of course, would be measured in human death, despair, and disease. And this decline in international resources is something which is causing enormous intellectual, emotional, and political convulsions in many parts of the globe. The other thing that is important to note about the declaration which emerged from the Summit on Non-Communicable Diseases is that, curiously enough, it did not set targets. It did not set goals. It was more abstract in its language and in its direction, and it shows, I think, how far we have yet to come in dealing with subject matters that the world has tended to ignore. Nevertheless, what Pat said seems to me to be not just shocking, but fundamental. 1 out of every 3 people in this country will be diagnosed with cancer. It will soon reach 1 of 2. And 50% can be reduced by 50%. There's something appalling about our inability to come together sufficiently to overcome the passivity and the rigidity with which these diseases are dealt, and cancer in particular. It is said that on an annual basis, the costs to the world of cancer and diabetes, those 2 non-communicable diseases alone, mount close to $1 trillion. So this is an intense economic phenomenon as well as an overriding human phenomenon. The statistical data is interesting. In 2008, the last year for which definitive statistics are available, there was something like 57 million deaths globally, of which 36 million were from non-communicable diseases, fully 63%. and way more than all of the deaths from AIDS, tuberculosis, and malaria put together. So you see that the world is suddenly beginning to understand that it is weighted with a kind of astonishing indifference to the march, the toll, the carnage of non-communicable diseases. And 80% of the measure of these diseases is now occurring in the developing world. And before, we always tended to think that cancer in particular, and diabetes, and pulmonary, and cardiovascular diseases were diseases of the developed world. They're not. They are overwhelmingly now part of the developing world. And when you meet ministers of health in the developing world, as I do with some frequency, they are frankly panic-stricken at the consequences of this new evident scourge. They can't handle it. They can't handle breast cancer. They can't handle lung cancer. They can't handle cervical cancer. The diagnostic capacities are limited. The laboratories' capacities are often non-existent. The treatment is problematic. There are no mammography screenings available. There is very little screening available for any of the realm of cancers. It's tremendously and profoundly disturbing as the recognition grows that we're dealing with a phenomenon for which there isn't an immediate answer. And people are, of course, impoverished. This realm of cancer is striking countries where a vast majority of the people live on less than $1.25 a day. And the World Bank estimates that the amount of money individuals and individual families spend, the disposable income spent to deal with non-communicable diseases, cancer in particular, is driving 100 million people every year into poverty. And those are numbers additional to those that now live in poverty. So the huge question becomes, what glimmers of hope are there? And one of the major glimmers of hope is the sudden, vigorous intervention of the World Health Organization, which has moved rather slowly in this realm, surprisingly slowly in this realm. Margaret Chan, when she was at the summit in New York, described cancer and other non-communicable diseases as a slow-motion disaster. And in the foreword to the World Health Organization study, she writes, "The consequences for societies and economies are devastating everywhere, but most especially so in poor, vulnerable, and disadvantaged populations. These people get sicker sooner and die earlier than their counterparts in wealthier societies. In large parts of the developing world, non-communicable diseases are detected late when patients need extensive and expensive hospital care for severe complications or acute events. Most of this care is covered through out-of-pocket payments, leading to catastrophic medical expenditures. For all these reasons, non-communicable diseases deliver a two-punch blow to development. They cause billions of dollars in losses of national income, and they push millions of people below the poverty line each and every year, and they cause astronomical pain and suffering and sometimes despair." And if that is the case in the developing world, surely in a country like Canada, we can rout 50% of the disease because we have all the sophistication and all of the medical apparatus and all of the laboratory tools at our disposal to make a quantum difference in the lives people lead. I'm reminded of a previous Prime Minister, Paul Martin, who at a critical moment in the fight against AIDS offered $100 million to the World Health Organization. It was a magnificent contribution for which he has received little applause, but it made it possible in so much of the developing world to put the experts into place in ministries of health who could then assist them in the provision of prevention, treatment, and care. And for Canada to do something of that kind again would be an enormous contribution to human well-being. In the Secretary General's personal report on this subject, which he tabled at the summit, he said, "Despite evidence of a global epidemic, NCDs are still not regarded by policymakers or the public as a global health priority. Behind this reality, there lies the consensus on the determinants: tobacco, alcohol, diet, sugar, salt, fat, obesity, physical activity, smoking. I was saying when I had a conversation with Mike earlier, smoking now accounts for 50% of the deaths from tuberculosis in India, let alone all of the cancers that it causes directly around the world: mesothelioma, lung cancer, colon cancer, so many of the most devastating cancers directly associated with tobacco. The Secretary General of the United Nations, a very modest and deferential and calm sort of fellow, not at all given to the rhetorical hyperbole that I'm addicted to. He speaks in calm and self-effacing ways, called the tobacco companies despicable. I've never heard that word cross his tongue except in that context. What is missing, and Simon can speak to this much more authoritatively than I, is a similar concentration in the developed countries, and particularly in Canada, on prevention. There's a lot of money raised, and there are these determinants that are identified. But on the prevention front, we're spending far less than we should be spending. And on environmental causes, we're spending almost nothing at all. And in workplace areas, where from uranium to asbestos, there is, of course, a terrible consequence of cancers, we still have a large road to walk. So even in this country, there are so many areas where we could intervene and make an ultimate difference to the lives people lead, and for whatever complex of factors we're not intervening. And what Pat says about asbestos should be etched in the conscience of the country. It is beyond belief that we are exporting death, and that we are exporting it willfully and knowledgeably. I don't understand it. I don't understand the government in this province, and I don't understand the government of Canada. There is no asbestos anywhere that is safe. None. And it is unimaginable that we are willing to sacrifice lives in developing country to support a relative handful of jobs in the Canadian economy. And it gives you, therefore, some sensibility about the areas where we can intervene, as Pat indicated. Secretary General's report goes on to say rather presciently, knowing how to reduce such diseases is not the problem. The problem is lack of action, end quote. And it's the action which we now hope to bestir in these fascinating series of encounters with universities across the country last year and this. A vigorous response to the social determinants which have caused the cancers and which we're familiar with in so many areas from the Government of Canada would make a huge difference. If you make of the responses a kind of cause célèbre, then obviously people would gather to it. Number two, it's necessary to confront powerful interests. Food manufacturers have to be dealt with. There are friends, as you can see, in the pharmaceutical industry with whom the campaign to fight cancer can have an association, but the cost of brand name drugs is something with which internationally we have to deal. Interestingly enough, in the declaration that came from governments on two separate occasions, there were references to the need for generic drugs to deal with costs around non-communicable diseases, cancer in particular, and the fact that the numbers and availability of generic drugs were in decline. Completely ironically, I spent an afternoon 3 days ago in London, in the UK, at the home of Yusuf Hamid, who is the CEO of a company called Cipla in India, the largest single generic drug company in the world. Yusuf was saying that there is a particular cancer drug which we pay $15,000 a year for in North America, and which Cipla produces for $200. and he was smiling, understanding that even the $200 provided him with a profit. And he didn't disavow the amount of money that goes into research and development on the part of individual pharmaceutical companies, which enormous costs that they absorb, and therefore the drugs themselves are of greater cost. But the availability of generics for countries that cannot possibly afford to pay what we can afford to pay through healthcare and through health systems, the availability of generics is a fundamental question. And as I say, this is not coming from me. This has been raised by the governments of the world. The Secretary General's report says, a study conducted in some low-income countries revealed that up to 2/3 of generic medicines were not freely available in the public sector, and almost 50% were not available in the private sector. And there is a strong wish to make them available on the part of countries, but interestingly enough, and I throw this out because in a university community, in an intellectual life of the mind, these are fascinating issues. The free trade agreements which are being negotiated between Canada and the European Union, between the European Union and India, are raising grave alarms about the possibility of extended patent protection for high-cost drugs when the world is more and more concerned about finding the generics. And isn't there some way to have both which doesn't compromise the financial integrity of either the generics or the brand-named producers? In the universities, you have this magnificent opportunity for research and the pursuit of knowledge. I love being at Concordia. Concordia has an extraordinary history, as most of you will know, of electric gathering of the forces for social change. It's an extraordinary environment. And students have this capacity to move mountains when they want to, and to rally the rest of society in the process. And I think of the extraordinary demonstrations that are taking place now on Wall Street, beginning to spread through much of the United States. Everybody thinking it wasn't possible. Suddenly, Obama and his colleagues wondering whether or not this is a phenomenon flowing from, quote unquote, the Arab Spring, which is about to take off in the United States. And might it gain a momentum which will have a significant influence on the elections in 2012? This artful use of the social media to galvanize a human response. It's growing. It can grow here in a different way, as the fight to control cancer is a struggle worthy of everyone's engagement, and no more worthy an environment than a university that has a legacy. I made a point of this, of a cauldron of social change. Dr. Lowy, I don't want you to have a cardiac arrest. I merely want to incite the students to respond with enormous vigor. Thank you, everyone.
Thank you very much, Stephen. Dean Lowy, Melanie, Mike, our panelists, Eduardo, and to our audience, thank you and good evening and bonjour à tous. I'm going to make a few comments about the burden of cancer. There are about 100 people in this room. Supposing you could get up and turn around and look at every person in this room, what you could say right now is 45% of the men in this room and 40% of the women will develop cancer in their lifetime. So we're really talking almost half the room. And if one were to say, and what will happen, of those who experience cancer, just under 50%, that will be the cause of their premature death. And if we were to put that in a global scale, we'd say, so multiply up those figures by 7 times 10 to the 7. And then you'll understand what the burden of cancer is globally. Now, many of you might say, but cancer, that's a problem really of the over 65s. Sure, cancer is the leading cause of premature death in the over 65s. However, it is also the leading cause of premature death in those aged 35 to 64. In fact, it claims more lives in that age group than cardiac disease, stroke, injuries, and diabetes cumulatively. Last year, 75,000 people died of cancer in Canada. Premature death, disability, and loss of function cost us as a society $300 billion in direct healthcare costs and loss of productivity. This burden will actually grow. It will continue to grow because we grow as a society in number and we age as a society. It won't grow proportionately, though. It will grow disproportionately. Those who experience adverse social, economic, and environmental exposures will actually bear the brunt of the increase of the burden of cancer. And so if we look at that, one might say these numbers are huge. The problem is enormous. That's absolutely true. But that in and of itself is not actually the challenge. That's a reality. Those are the figures. Those are the facts. That's what's going to happen. The real challenge to us is, so what choices are we actually going to make to change this reality? That will unfold unless we intervene. So what actually are the choices that we have? What could we actually do about this situation that's unfolding before us? I suppose in principle the answer is fairly simple. We could make informed choices. So what do I mean by informed choices? They really come in two types. There are those informed choices that represent the values that we express about health, life, and living, and the values that we express about illness, death, and dying. And if we look at those first choices, health, life, and living, so what things actually are important? Firstly, the investments that we actually make to reduce the adverse circumstances that affect health in our society. What are those? Poverty, homelessness, disability, isolation, gender inequality, differences in ethnic compositions, urbanization and the built environment. Whilst we take these as a sort of a background noise in the system, these actually are the major factors that determine the health of the population, and by determining the health of the population, have an enormous bearing on the predisposition to develop cancer as a consequence of living. The second thing we could do is actually make healthy personal choices about the things we do and the things that we engage in. For example, controlling the attributable risk factors of cancer, tobacco, alcohol, physical activity, diet composition. The third thing that we could do is we could actually avail ourselves of programs to diagnose cancer early, at a time when it is asymptomatic, and a time when it is eminently curable. Such programs exist for cervix cancer, breast cancer, colorectal cancer. It would appear they may be on the horizon for lung cancer. These are programs that define conditions where cure is an eminently achievable aspect of an early diagnosis. So those are three things that are totally within our power to express choices about health, life, and living. What do we think about death, disability, and dying? What's important to us there? Essentially, we'd like to make sure that the curable are cured. Accessible, high-quality, evidence-based care across Canada. We'd like to know that those who are incurable will receive care and be supported. We want person-centered care. We want informed choice. We want compassion and dignity. And finally, what really challenges us now is we want sustainability. We'd like a healthcare system that actually is dependable and affordable. And we'd like that without compromising our views of what a socially acceptable health environment is. So does our choice and our opinion actually matter? Can we actually reduce the burden of cancer? Is there a precedent for believing that's true? Well, the answer is yes. Those societies in the world that have the highest level of human development, which means have the highest level of control of premature death, have the highest levels of literacy and education, and have the highest standards of living expressed across the population, are those populations that have the best health outcomes. I didn't say the best healthcare systems. That probably is true. What I said was they have the best health outcomes. And there was an interesting comment from the American Cancer Society, I think earlier this year. If everybody in the United States had a university degree, 1/3 of cancers would be prevented. We can also make informed choices about tobacco. Statistics Canada has done projections in Canada around supposing we could reduce tobacco consumption in Canada by 50%. Currently, about 20% of adults over the age of 12 smoke. Supposing we could reduce it by 50%, what would be the consequence of doing that? The consequence would be 45,000 fewer people developing lung cancer, 33,000 deaths from lung cancer avoided, $1 billion of healthcare costs averted, and $32 billion put back cumulatively into the Canadian economy. Supposing we took advantage of organized screening programs to detect cancer early. Let's take colorectal cancer, again quoting from Statistics Canada. If 80% of the people aged 50 to 70 undertook annual fecal occult blood testing, 100,000 cases of colorectal cancer would be averted by 2030. 47,000 deaths would be avoided. 5.9 billion of healthcare costs would be averted, and 11.7 billion would be returned to the Canadian economy in that time period. Now one might say, well, that's in 2030, that's theoretical. Is change actually achievable? Well, again, the answer is yes. In California, 10% of the population over 12 take tobacco. In Finland, over 70% of the population undergo colorectal cancer screening. So these numbers are achievable by other societies, therefore, a priori, should be achievable by us as well. Is change absolutely necessary? These numbers would suggest yes, but perhaps another way of looking at it is, there is no doubt that healthcare as we practice it now is unsustainable in Canada. It is not unsustainable because the population is growing and getting older and cost of living goes up per year. That actually can be encompassed by revenue growth. What can't be encompassed is the discretionary way that the healthcare system is used and are accruing 5 to 7% of cost increases per year within the healthcare system when no revenue growth will actually support that. So we actually are faced with the consequence, if we value a healthcare system that is enshrined with the principles that we think are important, we actually have 3 choices. 1, raise taxes. 2, take it out of education, social services, transportation, and every other service that the public wishes. Or 3, rethink the way you use the healthcare system. And essentially, rethink it so that we no longer make it responsible for acute care, illness management, facility-based care, technology-driven care, and specialist-driven support. How do we become more informed if we want to express these choices? Essentially, we have to become engaged, we have to seek information, we have to provide opinion, and we have to make our views known. We have to express what's important, because essentially we're talking about what we pay for as a society and what we value as a society. So we have to make that known. Next year in Montreal, there will be the world's major cancer meeting, the UICC, in August. It will cover everything from cancer control, prevention, through to end-of-life care. There will be a further meeting later in October where the palliative care community of the world will meet in Montreal. Montreal is quite a hotbed next year of thinking about healthcare, cancer, and issues that affect society quite broadly. My message to you is the burden of cancer is huge, but it is not insurmountable. And the real issue that we face is whether we're prepared to make some choices that will actually bring it under control. My thanks to you.
Bonsoir. In Quebec, as elsewhere, cancer is the single greatest cause of death, and approximately 40% of Quebecers will be diagnosed with cancer at some point in their life. We know the impact of non-communicable diseases is enormous and on the rise, affecting individuals, families, communities, healthcare system, and societies worldwide. The path we are on is not sustainable, as we heard from previous speakers. The good news, if we can put it that way, is that there are actions that can be taken to stop many of these diseases in their tracks. Indeed, according to the World Health Organization, 4 modifiable risk factors are responsible for the development of most non-communicable diseases and include, as was mentioned before, smoking, physical inactivity, unhealthy diet, and alcohol abuse. Fortunately, these are factors we can act on to decrease not only the occurrence of cancer, but also many chronic conditions such as cardiovascular diseases, diabetes, chronic obstructive pulmonary disease, and osteoarthritis. The challenge before us then, according to the Public Health Agency of Canada, is, and I quote, to create healthier populations, to sustain our publicly funded health system, and to achieve a better balance between prevention and treatment, end of quote. This is our clarion call to action. Preventing non-communicable diseases is a societal challenge that requires a comprehensive strategy to create tools, new knowledge, and innovative products and services, as well as facilities and policies that inform, sensitize, accompany, and provide adequate support for people on their journey towards healthier life choices. So what does this mean? It means there is a part to be played by all members of societies, government, business interest, health and allied health professionals, education sector, and community sectors. But it is one thing to talk about individual change and quite another to make it happen population-wide. Our collective strategy needs to include readily accessible information, the availability of affordable and balanced food options, and access to well-equipped conditioning facilities and related expertise in our schools and in our communities. We also need to see society's entrepreneurs and business leaders developing and market goods and services that offer healthier lifestyle options. As for the university sector, what is it doing to improve population health, and could it be doing it better? It goes without saying that the university sector excels at traditional forms of knowledge transfer in terms of peer-to-peer, researcher-to-researcher communication of research findings, and of course it excels at teacher-to-student teaching and training. In Canada, our medical schools and comprehensive universities offer some 900 different study programs for health professionals and related clinical sciences. Within this wide variety of study options, university can play unique leadership roles in combating non-communicable diseases by building greater capacity for change and by connecting research and new knowledge to the widest range of people in the most effective ways possible. In order to better inform sustainable change, universities must widen their efforts in 5 interconnected ways. We need to, 1, focus on fields of inquiry that include a broader spectrum of population health research topics, such as improving our understanding of the multifaceted nature of affecting sustainable shifts in behavior, and how we can better accompany people through prevention and rehabilitation processes to ensure long-term success. This will involve seeking answers to the question of why so many people embark on a wide variety of diet, fitness, smoking cessation programs with the best intentions in the world, but do not stay the course in the long run. 2, adopt methodological approaches that include the concept of co-production of knowledge. 3, emphasize partnerships and collaborations to take a more integrated, multidisciplinary, and multi-sectoral approach to research and knowledge dissemination activities. 4, build synergies between university research centers and off-campus partners to maximize the use of our collective resources and expertise. And 5, conceptualize knowledge generation and dissemination activities so that they can occur hand in hand wherever and wherever possible. How universities will contribute to building society-wide capacity for change and connect knowledge and people will vary from one university to another. Medical schools immediately come to mind in terms of long-term planning for population health. Both the Government of Canada and the Government of Quebec have recognized the inherent need for social accountability and community engagement in medical education. In Quebec, the Ministère de la Santé et des Services Sociaux has placed a significant emphasis on the value of continuing education, particularly in oncology. Their recommendations apply not only to medical students and physicians, but to all health professionals in the field. For its part, Health Canada has openly promoted the requirement of community engagement for Canadian medical schools, citing it as a necessary basis for the expression of its social responsibility. As for comprehensive universities such as Concordia, that is to say universities without a medical school, we found ourselves strategically placed at the intersection of research and practice, often with specialization in community-based approaches. These approaches emphasize who university researchers need to engage and where. On the question of who we need to work with, the list includes clinical practitioners, community groups and leaders, decision makers, business people, healthcare professionals, exercise science specialists, athletic therapists, nutritionists, kinesiologists, sport trainers, psychologists, and neuroscientists. On the question of where, we need to create spaces where multidisciplinary and multi-sectoral encounters can be facilitated, possibilities explored, and partnerships cultivated. This includes on and off-campus sites such as university research centers, government and private research sites, hospitals and clinics, treatment centers, conditioning facilities, teaching environments, and community organizations. I could not give a brief presentation on the role of universities in transforming the global public health without sharing with you what Concordia is striving to achieve. Concordia's research excellence in the area of exercise science, psychology, and behavioral medicine recently facilitated the creation of the Perform Center through a $35 million investment from the Government of Canada and the Government of Quebec to the Knowledge Infrastructure Program. The name of this center, Perform, stands for Prevention, Evaluation, Rehabilitation, and Formation. It is a purpose-built facility designed to combine research, education, and community engagement in the areas of physical activity, rehabilitation, nutrition, and lifestyle change. It provides clinical validation of healthier living and preventable disease research, and it will deliver comprehensive services to researchers in clinical exercise physiology, athletic therapy, metabolic analysis, and medical imaging. And finally, it will offer programs to the general population, such as exercise, nutrition, and rehabilitation programs for people with heart or respiratory diseases, diabetes and metabolic disease, and for those living with cancer. Unique to Canada, because of the combination of these features all under one roof, the purpose of the Perform Center is to open up the research agenda to promote better health through prevention. This center also reflects a rapidly expanding North American trend in prevention-based research. It is an asset not just for Concordia University, but also for all participants and research collaborators locally, nationally, and internationally. In conclusions, there are many problems in the world we cannot fix. But in the case of cancer and many non-communicable diseases, there are things we can do something about. We are fortunate that there is a great deal we can do thanks to the extensive amount of scientific evidence linking key modifiable risk factors to these disease states. But it is not simply a question of individual responsibility and individual change. We need to develop a deeper understanding of the root causes of the environmental conditions as well as dependencies and unhealthy lifestyle habits leading to the occurrence of these diseases so that we can play a major role in motivating and supporting people to lead healthier lives. Merci et bonne soirée.
Good evening. It's a pleasure to be here on behalf of the pharmaceutical industry. And I say it like that because so far we've had a discussion, a very excellent discussion with such an esteemed panel on the subject of doing things differently, collaboration, working in partnership, and those are some of the themes I'd like to explore in some of the notes that I have for you. But in doing all that, it means talking with partners differently and engaging partners differently. And the pharmaceutical industry is one that has not necessarily been an industry that people always like to welcome to the discussion, partly because there's preconceived notions about what the industry is. And I have to share with you that I harbored a lot of those concerns myself. And before I get into my remarks, I'd like to share with you the little story that, 18 months ago, I didn't belong to the industry. I was involved in a different field, and it was proposed to me that I consider joining in the role of communications, a pharmaceutical industry, Sanofi in this case. And when the idea was put to me, I must confess, I stood back and I said, like heck, that's not an industry I feel like going to. And I decided to think about it a little bit more. The person who proposed the idea to me said, think about it a little bit differently. This company that we're talking about here wants to see itself as a player in the healthcare industry. Healthcare. And okay, so that resonated with me. I'm a mom. I have parents that I take care of. And I need this system for my own insurance. So healthcare is something I could buy. And then I asked somebody else, somebody quite close to me, I said, what do you think about this idea? And they said, why do you react so negatively right off the cuff? And I said, well, I'm like everybody else. I don't know much about this industry, and I only have a negative image. And they said, wait a second, if you think about all of the science that's behind this industry, if you think about all the developments over the last how many years, especially in the last couple of decades, it might be worth taking a second look. There's a lot here that this industry might be able to contribute, and it would be great to be a part of it. So that resonated with me, and it's with that that I bring you some remarks with respect to the specific issue of getting rid of cancer and dealing with chronic disease and non-communicable diseases. You've heard that non-communicable diseases are a scourge that, if not aggressively managed, could make the delivery of healthcare and the way we've come to know it, the way we've come to rely upon it, a thing of the past. But today I'd like to talk about the future of health. You know, what does that future hold? What does success look like? What will be required of all of us, and what will be the role of pharmaceutical companies in contributing to that future? But before I talk about that future, let's take a look at where we are and how we got there. Over the past decade, 3 major disruptions have occurred within our industry, creating what might be described as the perfect storm. First, between 2000 and 2010, our industry doubled its global investment in research and development. But over the same period, our R&D productivity, the ability to turn research into therapies, fell by 50%. This is a result of increased regulatory standards, pressures from those that pay for drugs like governments, and the many hurdles that we've got to overcome to get new drugs to market. Second, the drugs that have fueled our revenue and the R&D investments over the past 15 years are drying up. We've entered into a period of patent expiration, where drugs being launched in the late 90s and early 2000s are now being genericized, creating what is widely known as a patent cliff. And between 2010 and 2016, roughly $250 billion in revenue will be lost to the generic competition. When the Canadian economy contracts by just 1 percentage point, politicians start to sweat. Could you imagine the CEOs in the pharmaceutical industry when you've lost 25% of your revenues? Third, the market value of the top 15 pharma companies decreased by $850 billion between 2000 and 2008, prior to the first wave of global market turmoil, due to the cumulative effect of decreased R&D productivity, generic competition, and other factors. This massive retreat by investors has made it even more difficult for our industry to meet the many healthcare needs of our nearly 7 billion global citizens. I did the math when we were talking about 7 to the power of 10, so I got that part. In short, our industry is in need of a major transformation in terms of how we create value. And the old business model is dead, and new models have to emerge. So we have to look at the future in terms of a dialogue between doing well for the future, or doing good versus doing well. And I'll explain what I mean by that. 60 years ago, George Merck, the CEO of Merck, was speaking to the Medical College of Virginia, and he said, "We try never to forget that medicine is for the people. It's not for the profits. The profits follow. And if we've remembered that, they have never failed to appear. The better we've remembered it, the larger they've been." Decades later, in the 80s, Merck was named the most admired and best managed company in America for 7 straight years, according to Fortune magazine. This year, and this is pertinent because of the amount of discussion we've had about it by our previous speakers, this year, the tobacco company Philip Morris ranked higher than all 7 of the rated pharma companies in terms of image and reputation. How can that be? How can that be when we treat the diseases caused by smoking? In any event, compare George Merck's do-good way of thinking to the influential economist Milton Friedman. 40 years ago, Milton Friedman argued that the social responsibility of the corporation was limited to increasing profits. In fulfilling their duties to the corporation, he made the case that executives could do things that were in the interest of shareholders. This argument proved both compelling and practical, and measures like return on capital, earnings per share, and the market capitalization became the benchmark success of the corporation and the executives that ran them. The elegance of Friedman's corporate philosophy was that it allowed corporations to reduce all decisions to the common language of dollars and cents. Well, the problem is, it's really hard to put a price on human life. And I think that's how the pharma industry and others went astray 20 years ago. We listened to the ideas of Milton Friedman, but we forgot about George Merck. So now let's look into the future a little bit. Various pundits now predict that our healthcare system will become unsustainable in the next couple of decades if we maintain current spending levels. Healthcare spending in Ontario, Quebec, Alberta, and British Columbia represent the lion's shares of provincial budgets, somewhere between 40 and 45%. In fact, since 2001, provincial healthcare spending has been growing faster than provincial revenue. While it's clear to us that the sustainability of healthcare is what we need to keep our eye on, the solutions haven't come that easy. We've got lots of good ideas, but to date, the path to sustainability has been dominated by a singular, maybe ill-aimed focus, which is cost cutting. And there's nothing wrong with managing costs. But we can only squeeze so much juice out of a lemon. And we must also consider the promise of innovation, which is proven to be the sought-after method of improving productivity and driving recurrent savings. And so we should also consider changing the way we think about innovation. For example, health administrators have policies that reward true innovation at the expense of incremental innovation, the big thing. And we need to recognize that incremental innovation is a source of new ideas, where small improvements or breakthroughs culminate in the development of major advances over time. In the area of cancer, we're not prepared to fund medicines that increase life expectancy by 4 to 10 years, or 4 to 10 months rather. But over the long term, if we don't look at those medicines, then how can we continue to invest? How can we continue to ensure that we're going to make big breakthroughs down the line? 20 years ago, cancer was a death sentence. Today, we at least have some medication to prolong our life and to be able to manage our care better. But innovation's not just technical, it's also social. We need all the parts of our system working together to create, to test, and to deploy social and technical innovations in a way that is greater than the sum of its parts. And to illustrate that synergy, let me tell you a little bit about how Sanofi sees it. We're making some concerted efforts to move away from just product-driven focus to a focus that was on sick care, and towards a new way of looking at things, towards holistic vision of healthcare, the whole thing. We've made it our mission to let go of the traditional business model where we just try to sell drugs, to become part of a collaborative effort to deliver better health outcomes, as Simon's talked about, and Louise, in a more global way. We have to think about total solutions. We have to think about education, changes in lifestyle, nutrition, and other ways to prevent chronic disease. And this means that we've got to become more attuned to the challenges patients are facing and bring all of our resources, not just our medicines, to the common pursuit of solutions. Our people, our collective knowledge, and our proven ingenuity. And for example, we've started in the area of oncology to map the patient journey. To say, hey, how do patients and their families deal with all of this? And how could they better be served? We heard from Anthony earlier. We've started to look at things like barriers to physicians, to information, to psychosocial support, to medicines, and how do they use them? And we're looking deep and wide to determine how can we deliver the right mix of solutions. Education, devices, diagnostics, and that entreat the entire patient. This is being patient-centric. And we're also supporting diabetes management, another non-communicable disease. looking at things like health coaching, training for healthcare professionals who want to help patients be motivated to better manage their lifestyles. We've committed to creating a wealth of health economics data that help us to better understand the impact of disease. And this is a role that we can play in pharma. And finally, we've not only produced some of the world's best therapies for managing diabetes, but we've also developed educational programs for vulnerable populations, such as the Aboriginal communities, and supported research into areas like diabetic ulcers. This is really the tip of the iceberg. I'm really excited about talking about this again next year as we continue to advance. But we really do have to look at the patient's whole needs. We know that it's important to take a global view of healthcare and become an important knowledge partner and solutions provider to the benefit of patients in the system. So where does that lead us right now, right to today? Well, while Sanofi is convinced that we need a new business model along the lines that I've just been describing, we can't forget that the current model has solved or is significantly improving many of the world's health problems. Cancer is no longer a death sentence. HIV is treatable, and infectious disease are no longer the world's #1 killer. But our current model operates in a challenging healthcare environment. And here are a few points to support that. The one thing is that we know creating knowledge is expensive. This is particularly true in drug discovery and development. Bringing one drug to market can easily cost over $1 billion. And you're lucky if 3 out of 10 of those medicines get to market. Creating knowledge is risky. Late-stage failures in development phase or even after product launch are extremely common. Changing behavior is slow and difficult and expensive. Intellectual property, as we've discussed, also known as patents, are protected for shorter periods of time during which a large investment must be recouped. And if we're to make progress on our mutual objective of conquering chronic diseases like cancer, partners in this new model will have to find innovative ways to transcend these realities. It requires sitting down together. It requires synergy. And while Friedman may have gone too far, I do believe that the businesses in our industry are a proven vehicle for creation and application of knowledge and for balancing risk and reward. We just have to make sure that we don't forget George Merck. And so, in conclusion, it's why we're really pleased to be here today. The Campaign to Control Cancer truly believes that pan-Canadian social change can only be achieved when we engage society as a whole, when we sit together and where we collaborate and we explore new ideas. And what a great place to start that talk in terms of being in university. This speaking tour is based on the idea that to beat cancer, we need to create a dialogue between future leaders, our current leaders from business, academia, healthcare, government, and the public. We need to sit together. We need to sit with partners we haven't sat with before. And my commitment to you is that Sanofi will strike the balance. We'll maintain our commitment to improving the lives of Canadians and around the world, and we will stay focused on patients. But to be fair and transparent, we won't entirely forget Friedman. We do believe it's possible to serve shareholders and the public at the same time. So working with you, together, our opponent is cancer and other chronic diseases. They've never gone down easy, and there is no way that we can do it alone. Let's do our very best to achieve the promise of collaboration in order to beat cancer and improve health care for ours and future generations. Thanks.
Hello again. I'm going to pass these out. Should I? And there are microphones up at the top, just a couple of stairs up for you. Shall I give? I think we need a couple for the panel, and maybe we could pass one. We have three for the panel, and then the 2 microphones for the audience. Okay. So. Again, feel free to come up to the microphone and ask a question. I'm going to just ask one myself to kick things off. Simon, we had the rector of l'Université de Montréal into the CBC last week, who's a radiologist, Dr. Guy Breton. I asked him just in a series of really short answer questions to give marks out of 10 to Canada for cancer prevention. And he did not miss a beat before saying 3. How do you think we're doing?
Where 10 is really good and 0 is really bad. Is that right? I would say 3 is probably generous. I would say Canada, in fact, like most countries, has been persuaded over the last 50 years or so that therapeutic interventions are the answer to the cancer problem, and has turned its back on health as a societal issue and health as an issue that would lead to cancer. If we were to put a magnitude of effect on it, the power of therapeutic interventions to change cancer outcomes is at best modest compared with the power of prevention, or more so with the power of changing socioeconomic determinants of healthy living.
Pat, how did we get to the point where we're at a 3 or below in Canada with cancer prevention in a developed country? It seems unbelievable.
The emphasis, actually I'll go back a little ways. When I was diagnosed with breast cancer in 1987, I was 35 years old, and I worked in immunology research. And I was stunned. No one in my family had been diagnosed with cancer. There was no breast cancer. And here I was working in arguably one of the finest, I think, medical facilities in the country. It was problem-based learning. McMaster was known for being very progressive in its approach. And I got great care. I got absolutely no information about what I needed to do in terms of modifying my diet. No one even says, or says today, follow Canada's food guide. Get out there and exercise more. Ride your bike, swim, take your kids to the park. Nobody said it. But in the absence, you remember Susan Sontag's book, Illness is Metaphor. In the absence of true knowing, you make things up. I don't know what will prevent me from having a recurrence of my cancer, but I do know at a gut level what I need to be doing for myself and maybe for my daughters. And so back to your question of why we got to 3, our emphasis, our resources are all invested in the treatment of the disease, in part because we are being overwhelmed by the tsunami of people being diagnosed. And you cannot turn away, and this is true in the HIV/AIDS movement, as Stephen will say. You cannot turn away from people who are diagnosed and suffering. And when the investment in that, and there are so many people that you're having to deal with, that's where your resources go. And what is driving the spending in cancer control and the thinking about cancer control are government policies, obviously, and those are being driven in part by people like me who are advocates. But there is no public expectation for excellence, not in treatment. We will take 17 or 42-week waiting lists for post-lumpectomy radiation. We will accept that some provinces have no pap smear program, and yet we know these are life-saving. We accept less than excellence in a country that doesn't accept less than excellence in our standard for our cell phone use. So our investment is wrong-headed, in my opinion. And when you ask people, as we have done in community conversations, to host a conversation about cancer, ask your friends, your neighbors, your colleagues, and report back to us. What's important to you? What's working? What's not working? What do we do different? Time and time and time and time again. And not just in Canada, we did these conversations in 27 countries. Why are we not investing in primary prevention? Why aren't we making it easier for students, for university students, for employers? Why aren't we giving employers compensation because they encourage us to participate in programs that help us to stay healthy and prevent disease? So I hope I've answered your question.
Hi. First of all, congratulations. You are all amazing. And as a user of healthcare, of medicine, and of the practices that you encourage, I'm a beneficiary. I'm a 13-year beneficiary of colon cancer, of CLL, And I am passionate to bring forward a program that we've been working on called 1 in 3 to shock people. I asked a teacher, how do I get to the kids? Oh, you've got to shock them. So 1 in 3 shocks not only the kids, it shocks people of my age. They don't realize the extent of this disease. 1. 2, how do we turn people around to think in a different way? Education, yes, is very important, but we can't force them. So we have a lecture series that's been going on for 2.5 years now with Richard Beliveau on diet, with Bob Kilgore from the Perform Center, with Dr. Raz on mind-body, another one that's coming at the end of October on acupuncture and the benefits of acupuncture, and each one of these programs has to be scientifically based and accepted. We have a medical team at the Sequel Cancer Center that reviews everything that we're saying, everything that we're doing, but we're moving ahead. And the next thing now is we're developing a website. And by reaching the public, by reaching the youth, by using different modalities of communication, we hope to start to reach the youth. We need the participation of the corporations, almost like saying, can you produce products that are basically health positive? Cold FX has been a great success. It's made of natural products. There are lots of other things that we can do, and I do. I have a list that I consume every day of various health products, like flax or like other things, that people know a little bit about. But now there's some companies in the States that are starting to produce a dry form mixture of sprouted vegetables and sprouted seeds that bring forth that much more energy, and that can now be produced in such a way that the public can buy it. So we have a long way to go. But what do we do with the government? We're a political team. We have to go back to government and say, you're putting your nose in the wrong place. We've got to shock our politicians and wake them up to realize that prevention is how they're going to save the budget that they can't afford.
Yeah, and I just wanted to add there, in the program that I mentioned, the Cancer Day of Action, in 2012, it will be the 3rd year that we've done this. We've taken forward that message that what Canadians want, the shift that we want to see is towards prevention, not only in cancer, but in all NCDs and communicable diseases. That is a welcome, an absolutely welcome message to elected officials. I think you'll see, I know in British Columbia when they were bringing the Olympics to BC, they decided that they wanted to declare a mission that we will be the healthiest population in the world by the time of the Olympics. Now, having a big mission statement like that and getting politicians on board, but getting them on the record. And I know there are other people that want to ask questions, so we'll have to end it here. But maybe, Stephen, you want to comment on how you shift politicians' thinking.
I want to ask one more thing. The insurance companies charge you more if you're a smoker. What does the government do if you're a smoker? What do we do in other areas if you're going to be a diabetic because you're so darn fat? I'm sorry I'm being hard-nosed here. I'll leave it to you.
Yeah, well, Stephen Lewis, maybe we could, just before we come to the microphone.
When was the last time that anyone in this room heard the Federal Minister of Health talk about cancer prevention in an eloquent and continuous way? I don't want to play games with you. You all know my politics. But there is such an absence of political leadership around these questions of health prevention in the way that you've described, that's very much a part of the problem. And obviously citizen advocacy can possibly change that. But this kind of ideological resistance to moving into the field of social well-being around health prevention is mystifying. I don't entirely understand it, to tell you the truth, but it would make a great difference if they spoke out, and they don't, and that's part of our problem.
It struck me, I want to pick up on that point, Stephen Lewis. It struck me, though, that during the election campaign that Jack Layton missed an opportunity to put cancer right at the center of his campaign. And it doesn't feel like any political party does that.
Well, I'm not going to I'm not going to challenge a sort of retroactive assessment, but I think Jack probably felt, well, in fact, he was very public about his original prostate cancer, very public, and in that sense made of it a reality. I think he probably felt that it would be seen to be somewhat self-exploitative to make his own cancer a centerpiece of a campaign. I would think he would recoil from that, to tell you the truth.
We'll go to the microphone. Could you introduce yourself and then ask your question, please?
My name is Brenda Fuster, and I'm a proud 3-time graduate of Concordia University. My question is directed, I'm sorry, I don't recall your name, the representative from the pharmaceutical industry.
Joanne Kennedy.
Joanne. I realize you're probably doing a very tough job. You know, your focus, the focus of the industry is people who already have a disease and how to produce products to help treat or cure that particular disease. But with the emphasis today really on prevention, my question is, what might the pharmaceutical industry be able to do in terms of prevention? And the second part of this question is, logically, it's also an industry that works closely with universities, with medical schools. But I think there's a strong case, as we heard today, that comprehensive universities also can play an important role in disease prevention. So can you imagine, or what could you imagine the pharmaceutical industry doing in terms of working with comprehensive universities?
Thanks for the question. You know, I am very passionate about working with this industry right now because I am seeing a lot of initiative and efforts taking place right now in the area, no longer just on product focus, but really on this whole notion of cross the spectrum care. And prevention does play into this. I was talking a little bit earlier about the patient journey, for example, in oncology. And that's what we did was we did a study, and we're going to be releasing some of the material that our findings in the next little while because it contributes to the discussion. But looked at, for example, even in our system in Canada, especially in our system in Canada, all of the pain points, if you will, in terms of everything from pre-diagnosis and you know, the styles of life right through to if you ever got unfortunately diagnosed with cancer and how you'd go through it. And we're looking at what are the issues and how can we bring those to light and where can we provide a solution. So first you have to study the environment, so we've been doing that. So that's one step. The second step is your issue with respect to you know, how do you change lifestyles and how do you do things that are actively involved in the area of prevention. And that is another area right now where we really want to be involved in kind of waking people up to the fact that you need to manage your life. You need to manage your diet. You need to manage your lifestyles. Because if you don't, there's some negativity that can occur. And that's whether or not our company or any other company in my industry has a product to provide you. We have to do that. That's just a common good that we have to contribute to. There is a benefit in the end to all of us. You're going to be you're going to turn around and you're going to be able to get a service that'll help you to better manage your life. And if, God forbid, you should have a problem with respect to cancer or diabetes or something else, you know, there's a number of support systems there that, you know, a company like ours could help you with. So I want to make it clear that we actually are exploring what are those prevention, what is that change of lifestyle, what are those lifestyle management techniques that we can be looking into. This is something that's happening right now. With respect to the universities, yes, I think that's the collaboration part. That's the dialogue. I mean, we come here today, you know, maybe pharmaceutical companies weren't so apt to sit down and start to talk. Well, we got to start walking the talk. We have to come and have these kind of open dialogues about where can we be a more proactive partner. And here we are.
And I just want to add just very briefly to that about the power of young Canadians to influence not just the individual behavior change, but more importantly, what Simon mentioned and what Stephen Lewis talks about repeatedly are the social determinants of health. We may smoke and be fat in part because we're poor. And there's a direct relationship between those things. And I think what we might do for increasing the bottom line in terms of a minimum wage may do more to help prevent diabetes, heart disease, stroke. Don't underestimate the power, those social determinants of health that, as Simon says, are often the background noise. They're not background noise. They predetermine your risk, your kids' risk for generations to come. That's the role that government needs to be playing. That's the stand-up leadership challenge that's not being faced. So
I'll go to that microphone again, and then I'll come to you. Go ahead.
Thank you so much. I'm not going to use the microphone. I have a pretty powerful voice. Can everyone hear me?
Yeah, tell us who you are.
Oh, okay. Sure, of course. I'll do so. Thank you guys for all coming today. My name is Nick. I'm a proud student of this university. Before I begin, I did not plan on sharing this with people here today, but I was so moved by Anthony and his sharing of his story that I felt I would do the same. I want to tell you, and please, before, as a preface, I'm sort of called upon at this university through the Student Union to be a good moderator. However, if this does not go well, please excuse me, give me a free pass. When I was 7 years old, I want to tell you the story of an individual named Linda. Linda was my mother's maid of honor and my second mother. And one day, Linda, as she used to, came over and used to babysit myself and my younger sister because my mother was forced to go back to school because it was clear that as my sister and myself would grow older, that my father's already working over full-time salary would not be sufficient to support the family. And Linda, one day, she came over and she didn't look so well. And I asked Linda, I said, Linda, are you doing okay today? How are you? I'm 7 years old, I'm young. And she says, I'm doing okay, Nick. And I'm like, oh, I'm very sorry. I had fever, I must have given it to you. And she says, I'm going to be sick for a little while, Nick. And I need to let you know something. And she says, life is like a tree. And we are all leaves on this tree. And while maybe the middle of summer now, the fall will come, and then the winter will come. And when the winter comes, the leaves fall down off the tree. And when those leaves fall down off the tree, we must accept that and wait for the spring to come again. And I was then told that Linda had stage 4 breast cancer and also lung cancer and colon, well, not colon, it was bad, put it that way. Over time, despite this sort of knowledge that I didn't know at the time, I was given to it years later, she still babysitted my family while my mother was going through full-time studies. And one day, and she continued through chemo, she still babysitted. You know, one day she came and she had no hair. I said, that's kind of cool. I'm going to go do it myself. So I went and I went and got my hair shaven. And one day I went home expecting to see Linda, and Linda was not there. And my parents were there. And she said, the tree that was Linda has now fallen down. And I said to my parents, I said, so then we'll see her again in the spring. And my parents said, unfortunately, this tree is not going to regrow this time. And then I was told that Linda, despite being offered thousands of dollars through cancer support groups to go and travel the world and basically being told that she had a death sentence, continued to support my family and continued to babysit my sister and myself. At such a young age, we couldn't take care of ourselves. And she made this choice, despite having the opportunity to live her life. She was 42 years old. She made the choice to take care of my family when my family needed it most, and she gave her life for it. And my question today, and I hope you guys appreciate what I shared with you, is to the panel, what can we do as a society to not only help support those who are going through cancer, but everyone who is affected by it? How can we as a society redefine our priorities so that we can provide a proper social support group for these people who are going through these traumatic times? Because it doesn't affect just the individual themselves. It affects a whole network of people. And as there's a famous saying that says, you know what, it's very unlikely that you don't know someone or of some story of someone in your life that has been affected by cancer. And my sort of idea that I want to bring forward into the future is, how do we provide that social groups? How do we provide that social standing so that these people can continue to live their lives honorably, with respect, and with dignity? Thank you.
Nick, just before you step away, and thank you for sharing the story, what legacy do you think that Linda left you, her struggle with cancer, and how she reached out to your family even when she was going through such a difficult time? What legacy does that leave you with?
A sense that my life is only part of a greater picture, and that we as a society need to step up as individuals. And I sort of say this as an open challenge to my fellow students. Look at the size of this room and look how many people are in it. You know what? I congratulate everyone who's shown up here today, but this room should be full. This room should be full, and it is not. So I consider an open challenge to my students that have come to this university to show up next time Stephen Lewis and our esteemed members grace us with their presence on campus for the work that they do. Because we have clearly don't have a full appreciation for this, even though we try so hard to make it that way. And the legacy that I sort of like to think about is that this young woman, 42 years old, never smoked a cigarette in her life, perfectly healthy, was given a death sentence. And despite that, and despite having this sort of going on the sort of bucket list adventure that sort of comes to define people's lives sometimes at the end of that sort of process, she decided that it was more important to take care of my family when it was needed most. And I can assuredly say this, that my family and myself would not be here if it wasn't for her. And she gave up her life to give me the opportunity to pursue studies and pursue my passions. And she did so in a way that didn't make me feel guilty. She did so in a way that was with honor and dignity. So I guess if there's a legacy, I would say is that our lives are important and we should do good things in them, but we have to look at the bigger picture and see how we can help our fellow Canadians, our fellow global citizens in fighting the challenges that we have today, one of them being taking action on cancer. So I would like to hear from the panel, if possible, some ideas of how we can build this sort of social support groups. I have a very nice pamphlet right here, which I just picked up, which has a great list of them. But I would like to sort of hear about how we can maybe improve upon these ideas.
Who'd like to start? Maybe Simon.
One caution I would give is that one size does not fit all in everybody's wish to be supported. And there are those who find this a very private experience, and there are those who find it a very public experience. And one has to respect that people deal with it in ways that fit with how they will find healing. And so we have to be responsive to that. And I think our obligation is to ensure that we can be responsive to needs and match needs to where they are most appropriately placed. Maybe I'll stop there and come back. Pat, would you like to carry on with that? And I will.
I absolutely agree. And I think, cancer certainly changed my life, but in terms of how I reached out to people for support, and this was so long ago, there was no internet. It was a black hole of just my friends and family who, fortunately, many of them were involved in the feminist movement. And so I was swarmed with casseroles and potlucks and people hugging and kissing and smudging and ceremonies of all weird form. And that worked for me. But after a while, I wanted to be alone. I just wanted my family. My girls were 1 and 3. And I was told to go home and put my affairs in order. I didn't share that with anybody for a long time. I was mad as hell, and believe me, that showed, for about 10 years. But I think you need to also, that legacy, when I heard you telling your story, may well have been that act of serving others makes our lives meaningful. And we choose, and that might not have been an intentionally cognitive choice. I will serve this family, not go on the world tour. But we all do it in our own ways, but what I think we're all hearing, what we share in common, we all suffer. We all have losses. We lose our jobs, we lose our health, we lose our family, we lose someone we love, we lose relationships. And it's our struggle to make our lives whole again, to find the resilience and carry on. And then maybe it's going to be in service to others and maybe it's not, but make your life meaningful. So thank you for your story, I appreciate it.
Yeah, thanks very much, Nick. We're just a little bit past 7. Can we go to 7:30? Can we push it to 7:30? Is that going to be all right? I think we have a reception. 10 minutes? Let's try 10 more minutes. I'm going to go to the gentleman at this microphone here and just try to get a few of your voices heard.
Hi, my name's Charlie. I'm a student here at Concordia in the School of Community and Public Affairs. Thank you all for coming out and joining us today. As a student in the School of Community and Public Affairs, I was really happy to hear about all the community-based projects that are going on here at Concordia and elsewhere in Canada. And also, as a student in the Community Public Affairs, I have a vested interest in the public system and the public healthcare system. And my question is pointed towards Dr. Sutcliffe. It was just something that you mentioned, that you touched upon, and I wanted further clarification. And it was, you presented 3 options. The first was to raise taxes. The second one I didn't exactly catch. And then the third one, you mentioned that we have to take responsibility and rethink the way we use the healthcare system. And I was wondering if you meant that in a way that we have to rework it, or we have to bring services outside of the healthcare system as we know it now.
Right. So the basis of what I said was healthcare as we practice it now, with the expectations and the way we do business, is unsustainable. It is not because of the tsunami and the graying of the Canadian population. That actually can be encompassed, and we could continue. What is unsustainable is the growth in the way we use the services. Our discretionary use of the services is growing at a rate much faster than we can afford to pay for it. Now, if we accept that that is the case and that's how we will go forward, we only have 3 choices. So raise more money to pay for it, taxes. Take the money from things you're spending in other areas, like education, social services, transportation, etc. Take the money away from those and put it into health, which I think most people would say is unacceptable. Or recognize you can't continue to use health services the way that you are currently doing so. Now, why does healthcare cost us so much at the present moment? Largely because we have an acute care-driven model that's based on inpatient hospitalization, high use of specialist services, uses of technology, high costs of interventions, as opposed to models that would focus on things that are less costly. Is it possible for us to think about things that are less costly? Are there other models? I think the answer is yes, there are. The challenge to us is, and will they work with our social values, and will they work with the way that we think about healthcare in Canada? Our challenge is, you can't put off thinking about it. You can't imagine something different is going to happen in the future. Realistically, you have to face the issue. We have to think about these things and make choices.
Just as a footnote, all over the country, there are fascinating glimpses of preventive interventions which reduce costs dramatically. There is a doctor named Harry Rachlis in Toronto who's written a couple of books drawing on, it's R-A-C-H-L-I-S, written a couple of books drawing on examples and models right across the country that reduce costs and move to prevention and community-based care rather than facility-based care. And one shouldn't feel that it's impossible. It really is possible if we would set our minds to it. I think Dr. Sutcliffe is entirely right.
Thank you.
In the few minutes we have left, let's try to get some more shortish questions and answers, and I'll come to you next.
Hi, thank you.
What's your name?
My name's Bonnie. I work here at Concordia in the fundraising department. I'll try to keep my question coherent here. It really relates to education. I've had the privilege to spend a lot of time in the developing world actually and struggled with more on the HIV/AIDS side of things, how to respond to people that say things to me like, I just found out my friend has AIDS, but he's fine. He has a strong immune system. He'll be okay. When it comes to cancer prevention, education, how does one go about trying to educate populations that feel as though they have so many short-term, that feel as though they don't have that many options short-term, that are working in places and factories that many of us would say are obviously taking them in a direction that is more likely to lead to cancer, that say they smoke because they think it'll keep the malaria mosquitoes away, that don't have access to the food, and this has come up quite a bit, because of their socioeconomic status that will keep them healthier. How do you start educating these people on diseases so broad as cancer?
That has to be for Stephen Lewis, I think.
I'm not sure I'm catching it. Are you talking about it in the developing world or in...
Specifically the developing world. You spoke about, I mean, we have options, so many options when it comes to what we eat, our exercising, choosing not to consume alcohol the way so many do, choosing not to smoke. But for people that feel as though they don't have those options, or again, working in factories that, you know,
They sort of have a survival imperative just to make a living, a small living, and to worry about cancer prevention somehow doesn't make it into their top list of concerns and priorities.
How do we go about changing that?
I'm not sure I'm not sure I know. Obviously, the education system is crucial to that. But so are I don't want to be, again, somewhat abstract or romantic about it, but so are the multinational agencies. There are tremendous international agencies that have billions upon billions of dollars as an annual budget, and they have staff in every developing country, and they have direct associations with ministries of health and social and community affairs, and they do a very good job of educating the bureaucrats and the people who spread the word, and they get teachers together and do counseling and training. I mean, the World Health Organization, UNICEF, UNESCO, the World Food Program, these are organizations. UNICEF now has $4 to $5 billion a year. The World Food Program and UNDP have $6 to $8 billion a year. These are organizations with staff everywhere. And now, happily, we've just created a new international agency for women, which now has several $100 million a year and people on the ground and growing. So one shouldn't forget something called the United Nations, whose centerpiece on health is the World Health Organization, from whom we all take the guidelines. And they have staff on the ground, and they can introduce into an education system the kinds of material which will gradually bring people around. But it's a long, long, slow process because everybody is living on less than $1.25 a day, and they are frantic for survival, and they've got a famine in East Africa and Somalia, and climate change is wreaking havoc in Southern Africa, where disease and conflict are so transparent. I mean, it's a very tough long-term basis, but we do have agencies and NGOs like Doctors Without Borders, like CARE, like Save the Children, like World Vision, who have enormous capacity on the ground to help, not to direct, but to help.
These are the final two
And
questions.
I'm just going to make one more comment
Yeah.
on this to pick up from what Stephen said earlier. The tobacco industry spends in the United States and Canada almost $20 billion a year on marketing alone. If the UN decided to declare war on the tobacco industry, it claims it has.
Well, closer to home, we have
So I'll leave it at that.
two governments that are working to increase our asbestos exports. I mean, these, you know, we talk about difficult things in the developing world. There are things it seems one might do right here at home.
My name is Kamal Minhas. I'm a student from Carleton, part of the group that road tripped up for today. I read an article recently.
It's nice to see you.
Very nice to see you too. I read an article recently that, in light of Breast Cancer Awareness Month this October, cited that the breast cancer awareness industry, or the pink industry, will raise $6 billion this year. Not necessarily all for foundations and such, but also for commercial
reasons. And when I think of that, when I think of the movements that are taking place, what we do at Carleton is the Relay for Life for the Canadian Cancer Society. And in the past 2 years, we've raised over $100,000, and this year we plan to raise another $100,000. But where is that funding going? To the Canadian Cancer Society. We found a very cost-effective, efficient way of bringing this issue of prevention into our campaign. What we do is we run a committee of about 30 students who put together this event. And of that, it's 10 committees. And we've dedicated a committee to the Campaign to Control Cancer to create not just an event-based campaign, but an experience-based campaign. So we have community conversations around cancer that we try and do bi-monthly. And it's a very cost-effective, easy way to mobilize what's already there. We have walks happening monthly. You have Breast Cancer Awareness Month, Movember, Julina now. There's so many different types of movements that are happening, and to mobilize young people as a young person, we're having very conversations about the macro side of the issue. But how are we mobilizing towards prevention with what's already on the ground, with these movements? Is there any way for the Campaign to Control Cancer to mobilize all of these different foundations and organizations to just incorporating a part of this prevention idea, or this just creating these conversations through what already exists? Is there any model or mechanism through which we can help do that? Versus, like it was said before, this room should be full. 100% this room should be full with students who are engaged in this issue. I alone, in my first 3 years of university, had 2 scares with cancer, both preventable because at the age of 18, I need to give myself a breast exam and I need to get regular pap smears. And that's prevention, acting 100%.
And Kamal, welcome back. And welcome to all the students who join you. I mentioned in my comments that out of last year's tour came a demand from students who said it was great to be inspired by Stephen Lewis. What else have you got for us? What action do we take? What do you want us to do? Be really clear. So you got that checklist today, but you also got the project that Kamal and the C2CC, our group, are working on. It's called Engaging Emerging Leaders in Cancer Control. So that's the project that we hope will eventually grow to universities across the country. $100,000 would be half of my organization's budget for a year. If you want to make a difference, I have to make this pitch. We're really glad Sanofi Aventis is here with us and that they've been here for 10 years. But when you're an advocacy group, you don't have the option of providing people with a charitable donation. So your $10 or $25 when you contribute to the Run for the Cure of the race, it's going to research, it's going to the future. But we're saying right now, let's apply what we know right now. Let's engage students right now. And that, I just want to end it there because I think, there's more that's going to come. A year from now, we hope there'll be campaigns across the country. So.
Well, you were so eloquent at Carleton, and you were so engaged. I've mentioned this at other places. I didn't mention it today. There is a new documentary done by the National Film Board, which will begin to get circulation in Canada in the month of November. It's by Canadian filmmakers. It's called Pink Ribbon Inc. And when you've seen the documentary, you'll start asking yourself questions about where all of the money that's being raised under Pink Ribbon campaigns is actually going, and why we're at less than 3 between 0 and 10 for prevention when so much money is in fact being raised, and who is benefiting from the money amongst the product sponsors who drive so many of the Pink Ribbon campaigns. It's something that students should think about and look at hard. It doesn't mean we diminish the fundraising around cancer. It must continue. But it means how the money is used becomes more and more a focus.
Time is short. We have some people have planes to catch. This is the last question up at this microphone.
Good evening. My name is Bonnie McBride. I have one question for 3 members on the panel. But before I ask this question, I would like to say to Stephen Lewis, when the Liberals were in power, they offered you irresistible jobs abroad. I so wish you would now consider running for the leadership of the NDP.
First of all, I'm very happy in what I'm doing. Liberals never offered me a job. What are you talking about? I know they never offered me a job because nothing in my life would have given me greater pleasure than to say, take your job and...
Your question.
Thank you for clarifying that. Pat, I'd like to start with you and then with the other two doctors on the panel. Considering that tobacco is legal and yet 50% of cancers are preventable, do you feel the birth control pill contributes in any way to cancer that women get? And I'm not interested in the studies that are studied by the pharmaceutical companies because I believe they are not unbiased.
Okay, Pat.
Do I think the pill causes cancer?
Yes.
No, I don't. I think there's enough evidence over a long enough period of time, over a big enough...
Funded by whom?
Pardon me?
Funded
Let me tell
by
you a
whom?
real quick story. I worked for Searle Pharmaceuticals in 1970, around 1974-75. I was a medical technologist, actually I was a research technologist, and my job was to sample raw estrogen as it was shipped in huge barrels, wearing a mask. I would go in and I would create clouds of aerosol estrogen, and I would breathe it in. 10 years later, I developed breast cancer. No family history. Now, I thought Searle Pharmaceuticals and their damn estrogen gave me breast cancer, and I was mad as hell. Had I been right, and believe me, I was pretty rigorous about what I was going to expose myself to there. There should have been, among that population of people who were working in the industry, a significant increase in cancers, women's cancers, breast cancers, ovarian cancers, etc. And believe me, a lot of the people I worked with were not as diligent as I was. But it wasn't there. As much as I wanted to believe it and hate that company for having taken away my health and scared the hell out of me, and my little girls were a great inspiration for me on this one to make it right, it just wasn't so. So I let it go, and now I'm after the things that we know cause cancer. I don't need to make stuff up. I don't need to go looking for trouble. It's right there in front of us. Let's apply what we know and fix the things we can. And where we don't understand the behavior change, let's make it easier for people. Let's do that science.
And Bonnie, that's going to be the last word, I'm afraid. And Melanie, you're going to come up and say a few words. And thank you very much, everyone, on behalf of myself. Thank you very much for coming. And thank you.
Thank you very much, Mike, for moderating such a good discussion. I would like to take this opportunity to thank the speakers at the event, the Campaign to Control Cancer, for bringing this event to Concordia, to Sanofi Aventis for supporting the series. And I'd also like to thank all the partners who are involved in the screening, et cetera. You see all of their pamphlets at the top of the stage, and also when you leave, you'll see a number of partners who are trying to help us deal with this issue. Finally, I'd like to extend my thanks to you, the audience, for participating, for asking questions, for challenging us, for sharing tender moments, to make this all really an event for us that we can hopefully go away from and we can think about in days to come, but also try to find a way to act. Pat was talking about some of the documentation that can come forward from the Campaign to Control Cancer to Concordia. I just want to say that for any of the students who really do want to get something going here, please contact me. I'm easy to find. I'm on the website. We have health promotion specialists who work at Concordia in health services, but we can't do it by ourselves. And I'll have to tell you, as a woman who's over 50, it's sometimes hard for us to know how to connect to students to make this really an issue for you. For those of us who are over 45, we already know that cancer is an issue, but it's not the same as trying to have young people understand that it's something that they can help us with and that they can actually change their behaviors so that they don't end up in that 1 in 3 and 1 in 2 ratio that we have here. So I'd like to thank everybody for being here and all of the people at Concordia who helped me put this together. For those guests who are invited, I'd ask you to remain seated. For the rest of you, I want to wish you a good evening and thank you very much.
What is the distinction between those who are invited and those who are remaining seated?